Okay, a very warm welcome to everyone, and thank you very much for everybody who's joined us live for today's session, and then also a very warm welcome to those listening in afterwards to the recording. I'd also like to warmly welcome our guests today, who I will shortly be introducing. My name is Ellen Scharfeutler, and I am a Professor of Pharmacy Policy and Practice at the University of Manchester. FIP's or FIP's vision is a world where everyone benefits from access to safe, effective, quality and affordable medicines and health technologies. Our mission is to support global health by enabling the advancement of pharmaceutical practice, sciences and education. We're very pleased to be delivering this event entitled Removing Policy Barriers to Pharmacist Vaccinations. That's under the FIP DG 13 policy development. And I think we can move to the next slide. Okay. So just a few housekeeping rules before I go into more detail. So please note that this webinar is being recorded and it is being live streamed via Facebook. This recording will be freely available on the FIP website. You may ask questions using the question box that's provided in your Zoom functionality. You're also welcome to provide feedback to the email address here, webinars@fip.org. And please, if you're not already, do become a member of FIP and encourage your colleagues to do the same. Okay, as I said, my name is Ellen Scharfeutler. I'm going to moderating today's session. I'm a professor at the University of Manchester, and I'm the director of the Centre for Pharmacy's Workforce Studies there. And I've got over 25 years experience undertaking health services and pharmacy practice research with a particular focus and interest on pharmacy policy. And I've done quite a bit of research in the area. I'll hand over to Chima, who I suggest if you can introduce yourself, who'll be helping me and co-moderating today's session.
Hello, everyone. Welcome to today's session. I'm Chima Amadi. I'm co-moderating this session with Ellen. I'm education and training personnel at Pharmacist Council of Nigeria. So together we'll be moderating this session. I look forward to all the discussions and to the panelists as well. Thank you for being here. So back to you, Ellen.
Okay, thank you very much, Chima. So as I said, welcome now specifically to today's programme, which is transforming vaccination regionally and globally. So this is the first FIP transformation outcome-based online programme of its kind, and it's underpinned by the FIP development goals. And the final outcome of the programme is a historic global FIP commitment to action on vaccination in pharmacy. And that's an FIP transforming vaccination collection of 2021. So that's what we're working towards. Just to locate today's session in a series of 3, we are at midpoint in series 2 here. So series 1 was all about starting in September and it runs through December. Series 1 was about identifying transformation needs. So specifically the needs of the pharmaceutical science, practice and workforce. what we're doing today is thinking about setting transformative goals. So it's about deconstructing vaccination in pharmacy through the FIP development goals across the entire profession. And then we'll move, not today, but at a future date before December, to series 3, which will be about committing to transformation. Okay, so we'd really urge you to please engage with us and help FIP to answer those questions. So we've listed here 3 different questions which we would encourage you throughout the session to give this some thought, and by all means please type your suggestions, answers or further questions into the question and answer or the chat box on Zoom. So we're particularly interested to hear from different countries what the single factor should be prioritised to transform pharmacy vaccination services globally and regionally, and what you think will be the most important achievement in terms of pharmacy vaccination services in your country in the next 5 years. And actually also, what else should FIP commitment to action outline? So I'll leave those questions with you, and as I said, would encourage you to put answers into the chat box. So we're now moving to today's learning objectives. Which are about understanding the impact of FIP Development Goal 13, which is policy development in the transformation of vaccination globally and regionally. So our main outcome is to understand this impact today through presentations. So we've got all together, we have 3 speakers, first of whom I'm now going to introduce to you. So thank you very much for Walter da Silva João, who's the president of the Brazilian Federal Council of Pharmacy. Just a brief background biography about Walter. He graduated in biochemical pharmacy at the Federal University of the State of Pará in Brazil. He mastered in nutrition and food science at the Nutrition Institute of the Central America and Panama in Guatemala. He heads the Brazilian Federal Council of Pharmacy and has led the fight for the approval of important regulations for the pharmaceutical class, such as the ones that regulate clinical attribution of pharmacists, the pharmaceutical prescription, and the role of pharmacists in floral therapy, anesthetics, and blood perfusion. So just a note here about this speaker. If you would like to listen to this in English, if you can please go to your function in your Zoom and change your language preference to language interpretation and select English, you will be able to listen to Walter's presentation in English. And I'll hand over to Walter now. Thank you very much.
Ok. Quero, a princípio, apresentar os meus agradecimentos pelo convite para participar deste painel. E eu vou procurar, durante a minha apresentação, me atentar para uma apresentação, uma abordagem objetiva, atendendo ao tema que foi proposto para este painel, ou seja, né, as políticas para suplantar as barreiras que dificultam a inserção do farmacêutico nos programas de vacinação. Né? Next, por favor. Como vocês podem ver nesses dados, desde 1973, o Brasil implantou um programa de imunização gratuita, sistemática e em massa da população brasileira. Programa Nacional de Imunização no nosso país, ele disponibiliza o acesso a todas as vacinas recomendadas pela Organização Mundial da Saúde. E o principal objetivo desse programa, ele consiste em buscar ou controlar ou mesmo eliminar e erradicar as doenças de importância epidemiológica para o país, como, por exemplo, o sarampo, a poliomielite, a difteria, o tétano, a coqueluche, a febre amarela, a hepatite B, a rubéola, e até mesmo as formas mais graves de tuberculose. E como vocês podem observar, esses dados que estão aí sendo apresentados para vocês são dados fornecidos pelo Ministério da Saúde e que mostra que temos uma capacidade instalada de cerca de 36 mil salas de vacinação espalhada por todo o território nacional. Né? E, dentro desse programa, anualmente, o Brasil administra algo em torno de 300 milhões de doses de vacinas, com um custo que é de quase 4 bilhões de reais para o sistema de saúde, o nosso sistema único, o SUS. Né? O que é importante destacar nesses dados é que não há, dentro desse programa, nenhuma contrapartida, copagamento ou qualquer tipo de desembolso por parte dos pacientes. Next. Dentro do contexto da vacinação, o que nós podemos observar é que, nesses 47 anos de existência, o Programa Nacional de Imunização no nosso país é uma das políticas de maior cobertura, impacto e sucesso entre as políticas de saúde do país. E foi exatamente isso que possibilitou erradicar todas essas doenças, como já citei, a poliomielite, a varíola, a rubéola, entre outras. Entretanto, eu preciso deixar claro para vocês que a efetividade do nosso programa, ela encontra-se, num certo sentido, ameaçada. Né? Pela primeira vez, poderia dizer isso para vocês, ao longo desses anos, o Brasil não alcançou a meta de cobertura vacinal. E é claro que nós temos alguns fatores que contribuíram para isso. Next. Como, por exemplo, nós encontramos e enfrentamos um problema crônico de financiamento do Sistema Único de Saúde e que, naturalmente, se agravou com a crise econômica e a imposição de um teto de gastos públicos com a saúde desde o ano de 2016. Então, a fragilidade também é outro que contribuiu para isso, para a não cobertura da cobertura vacinal no país, foi a fragilidade dos dados oficiais sobre a cobertura vacinal. Houve também uma acomodação por parte da sociedade, ou seja, uma percepção de que não há necessidade de vacinar. Isso vem acompanhado de todo o movimento de desinformação no meio da sociedade. Seria um movimento anti-vacina através da disseminação, principalmente, de fake news nas redes sociais e que tentam desacreditar e questionar a segurança das vacinas. Next. Para enfrentar todas essas dificuldades, essas barreiras, para remover essas barreiras que dificultam a inserção do farmacêutico no país, eu gostaria de dizer para vocês que, no Brasil, existe um marco legal do Sistema Nacional de Saúde, que é o que nós chamamos de Lei Orgânica da Saúde. Ela estabelece que a assistência farmacêutica é um direito universal, e que deve incluir a assistência farmacêutica. E é neste sentido, que a pauta de participação dos farmacêuticos nas ações de imunização faz parte da visão estratégica do Conselho Federal de Farmácia, que defende reorientação da farmácia brasileira para a provisão de serviços farmacêuticos. E, claro, que exatamente dentro deste cenário, o Conselho Federal de Farmácia, como entidade nacional que representa e advoga, defende pela efetivação de políticas farmacêuticas que garantam o acesso à sociedade brasileira à assistência farmacêutica como um direito da sociedade, como um direito social em saúde. Defende também que o aproveitamento da força de trabalho dos farmacêuticos é como um recurso que pode reforçar o Programa Nacional de Imunização e contribuir para a recuperação e ampliação vacinal em todo o nosso país. Next. Nessa transparência, nesse slide que está sendo projetado para vocês, a gente dá um foco do que é que o Conselho Federal de Farmácia tem feito, né, para romper essas dificuldades, romper essas barreiras. Né? Primeiro passo foi nós elaboramos, para implementar, nós procuramos definir uma agenda estratégica de ações políticas orientado pelas seguintes táticas. Primeiro, buscar uma unidade de ação. Depois, mobilização de toda a categoria, entidades, etc. Depois, articulação política e também promover, em função de tudo isso, a visibilidade social do farmacêutico. Então, nós procuramos buscar pautar, né, pactuar algumas ações conjuntas entre as entidades e as organizações da profissão farmacêutica no Brasil. O Conselho Federal de Farmácia, nesse sentido, ele iniciou uma gestão política visando abrir, manter e ampliar canais de diálogo com o governo, com o parlamento, com os players do setor, como, por exemplo, o setor da indústria, o setor do varejo farmacêutico. E a busca desse diálogo com setores e organizações da sociedade e também com outras profissões da saúde. Nesse sentido, nós passamos a investir na criação, inclusive, de canais de comunicação interna com a nossa profissão. Next. Pois bem, como vocês podem ver nessa imagem, a mobilização que viabilizou o resgate do papel do farmacêutico na imunização da população brasileira teve o Conselho Federal de Farmácia do Brasil como seu principal articulador. Nesse sentido, o Conselho coordenou a criação do Fórum Nacional de Luta pela Valorização da Profissão Farmacêutica, que aglutinou todas as entidades estratégicas da profissão: o Conselho Federal de Farmácia, a Federação Nacional dos Farmacêuticos, a Federação Interestadual dos Farmacêuticos, representando a área sindical, a Associação Brasileira de Educação Farmacêutica, que reúne os representantes da área acadêmica, e também a Executiva Nacional dos Farmacêuticos, que representa as entidades estudantis de farmácia do nosso país. Next. Essas imagens mostram para vocês, né, que o nosso fórum ele propôs mudanças decisivas no projeto de lei sobre a farmácia comunitária, a farmácia privada, que estava em tramitação no Congresso Nacional. E, na defesa dessa nossa proposta, mobilizamos farmacêuticos do país inteiro, que pararam a esplanada do Ministério, que é a principal via do poder político na capital do país. Portanto, observe, juntos, entidades, categoria, construíram um consenso, que eu diria para vocês, jamais imaginado. O texto proposto ele foi endossado pelos representantes da indústria e do comércio farmacêutico, mas também pela liderança de todos os partidos políticos representados no Congresso Nacional e pelo Poder Executivo, representado pelas autoridades do Ministério da Saúde, a Agência Nacional de Vigilância Sanitária, da Casa Civil da Presidência da República. E recebeu ainda moções de apoio do Fórum dos Trabalhadores da área de saúde, o FENTAS, do Conselho Nacional de Saúde e da própria FIP, que nos deu um grande apoio no Congresso da Tailândia, em Bangkok, na Tailândia, em 2014. Next. Ainda sobre essa mobilização, qual foi o resultado alcançado disso? De toda essa mobilização? Foi a aprovação da Lei 13.021, em 2014, em que se reconfigurou a natureza da farmácia comunitária, inserindo o seu interesse e propósito social como estabelecimento prestador de serviços e oficializou em todo o território nacional o serviço de imunização como uma das atividades permitidas nas farmácias comunitárias. Como vocês podem ver, à esquerda dessa imagem, o que referencia o artigo 7º, que possibilita as farmácias incluírem e poderem disponibilizar vacinas, soros, etc., que possa atender ao perfil epidemiológico da população. Next. E qual foi a principal articulação política? Ou seja, a aprovação dessa lei marcou a transformação. Com ela, nós rompemos as barreiras que ainda dificultavam a inclusão do farmacêutico nos programas de imunização no Brasil. Então, vocês podem ver nessas imagens que nós reunimos nas imagens com a diretoria da Anvisa, né? Embaixo, tivemos trabalhando numa articulação e criamos a frente parlamentar com a atuação do farmacêutico na imunização, né? E esse marco legal e conceitual da farmácia comunitária no Brasil era necessário para mudar a visão da farmácia comunitária de um estabelecimento puramente comercial para uma unidade de provisão de produtos e serviços de saúde. Neste caso, né, nos referimos aos serviços farmacêuticos. Portanto, uma vez aprovada a Lei 3021, o CFF buscou a abertura de canais de diálogo com o Ministério da Saúde e com a Agência Nacional de Vigilância Sanitária, como vocês podem observar nas imagens, nos temas referentes à regulamentação dos serviços farmacêuticos, entre eles o serviço de imunização e também a realização de testes rápidos em farmácia. Mais recentemente, já para 2017, a Anvisa, que é a nossa agência reguladora de todo o comércio farmacêutico, a Anvisa, Agência Nacional de Vigilância Sanitária, que se equipara à FDA americana, publicou uma resolução de número 197 que regulamentou os requisitos mínimos para funcionamento dos serviços de vacinação humana. Essa agência, a Anvisa, também revogou a portaria conjunta Anvisa-Funasa de 2000, e essa sim era a maior barreira que nós precisávamos derrubar, né, porque ela restringia os serviços de imunização privados a clínicas médicas. Quer dizer, ninguém mais poderia prestar serviço de imunização a não ver as clínicas médicas. Nós suplantamos essa barreira porque nós revogamos essa portaria. Tá? E agora, em 2014, com o advento dessa RDC, dessa resolução da Anvisa, ela veio ser um divisor de água, pois abriu aos farmacêuticos a possibilidade, além de aplicar a vacina, responsabilizar-se tecnicamente pelos estabelecimentos onde esses serviços é ofertado. E agora, em 2018, o próprio Conselho Federal de Farmácia regulamentou a Resolução 654, que regulamentou os requisitos necessários à prestação do serviço de vacinação pelo farmacêutico. Né? Com um aparato, claro, normativo garantido, o Conselho tem atuado no sentido de ampliar a participação dos farmacêuticos na vacinação. E, recentemente, para vocês terem uma ideia, o Conselho participou do lançamento da Frente Parlamentar, como disse, e mostra as imagens, ao Programa Nacional de Imunização. Todos esses esforços visam, na realidade, posicionar a categoria farmacêutica como interlocutora, que possa influenciar na tomada de decisões políticas para o setor da saúde. Próximo. Tudo isso trouxe para a nossa profissão no Brasil uma grande visibilidade social. Vejam nas imagens, né? Nesse sentido, o Conselho Federal de Farmácia desenvolveu ações de promoção da imagem, como disse para vocês, da imagem social do farmacêutico junto à opinião pública. E, naturalmente, isso incluiu o engajamento em campanhas sanitárias, tanto de promoção como proteção à saúde, tá? A elaboração de materiais educativos e peças promocionais junto aos meios de comunicação. Por outro lado, a emergência da pandemia da Covid-19 no país colocou mais em evidência o papel que os farmacêuticos e as farmácias podem desempenhar não só no acesso à imunização, mas a outras ações de saúde essenciais, na prevenção, na mitigação e contenção de surtos epidêmicos. Todas as nossas farmácias privadas participaram da última campanha nacional de vacinação contra a gripe em várias localidades do nosso país, como em Campo Grande, no estado do Mato Grosso, São Paulo e também no estado de Minas Gerais e Rio Grande do Sul. Em Porto Alegre, no Rio Grande do Sul, localizada, portanto, na região sul do país, né, a participação das farmácias comunitárias ampliou em mais de 1/3 os pontos de vacinação, e num cenário nacional de redução, vejam bem, de redução da cobertura vacinal. A participação das farmácias nessa cidade, Porto Alegre, sem dúvida que contribuiu para que o cumprimento de 83% da meta de imunização em idosos fosse alcançada em apenas uma semana. Vejam só, de um total de quase 720 mil doses aplicadas durante a campanha de influenza, 155 mil foram feitas por farmacêuticos, em farmácias privadas, ou seja, 22% do total. E o serviço de vacinação em farmácias, ela se ampliou a cada dia. Vejam só, em 2018 e 2019, 150 mil doses de vacinas foram aplicadas nas mais de 300 farmácias brasileiras. E vale ressaltar que o país hoje, o Brasil hoje, ele conta ainda com 12 clínicas de vacinação de propriedade de farmacêuticos. De novo, estas ações buscam articular valores como mobilização, engajamento, visibilidade e empatia, claro, e empatia social. Next. Mas, finalmente, eu queria dizer para vocês que o Conselho Federal de Farmácia ele tem investido também no desenvolvimento profissional do profissional farmacêutico no Brasil, por intermédio da oferta de cursos e programas de treinamento e educação continuada voltados para o cuidado farmacêutico, incluindo, nesse caso, um programa, incluindo o módulo de imunização. E, adicionalmente, o Conselho iniciará agora em 2021, início de 2021, um programa específico para preparar e certificar os farmacêuticos vacinadores para atuarem tanto nas farmácias comunitárias, clínicas de imunização e nas unidades do Sistema Público de Saúde. Vale dizer que nós já capacitamos milhares de farmacêuticos como vacinadores. Pois bem, eu queria só para finalizar, efetivamente, quero dizer ao final desta minha fala, que neste momento tão crucial que a humanidade enfrenta com a disseminação de uma grande pandemia, eu gostaria de ressaltar que a garantia do acesso a vacinas, mais do que uma conquista da ciência e da saúde pública do nosso tempo, constitui um imperativo moral, um direito social e uma conquista da sociedade. Portanto, para nós do Conselho Federal de Farmácia, trata-se de uma questão de respeito a um dos direitos humanos fundamentais, o direito à saúde, o direito à vida. Muito obrigado.
Thank you very much for this very interesting and insightful presentation. I suggest that I can't see many questions in chat at the moment, and in order to keep us on track for timing of this presentation, I suggest we go to speaker 2 now, who I'll introduce in a moment, whose picture you can see already, and then we'll see how much time we've got left at the end, and we'll pose some questions to the whole panel of our 3 speakers at this point. So our second speaker is Howard Rice, who's the President and International Liaison Officer of the Pharmaceutical Association of Israel. After practicing as a community pharmacist for 40 years, Howard completed an advanced course in consultant pharmacy at the Ben-Gurion University. He now practices as a consultant pharmacist on correct medicines use and problematic medicinal combinations. He also serves as the pharmaceutical consultant and undertakes research and development projects for a number of companies, and he's served on many government committees pertaining to pharmacy. His interests have always focused on CPE, having both learned and lectured nationally and internationally on the added value of pharmacists. Over to you, Howard.
Thank you very much indeed, Ellen. Well, dear colleagues, wherever you may be, my name is Howard Rice, as mentioned, and I want to thank you for joining this FIP initiative to learn by the successes and mistakes of others in this remarkable FIP family. And this, despite the difficulties that we have in these very, very challenging times with Corona. As pharmacists and pharmaceutical scientists, we perhaps better than most see the advantages and dangers, opportunities and problems in health systems, both nationally and internationally. There can be no better example of this than in the logic of pharmacists administering vaccinations. In 2016, a revision was made by the Israeli Pharmacy Ordinance. It would save both lives and money, and we felt that we were entering into the Garden of Eden. But soon we found there were stumbling blocks before this pharmacy vaccination legislation, and this is the essence of my presentation. Could we have the next slide, please? In late 2016, as I said, this legislation was introduced, and that became a law in 2017. Consultations had to be given to both at the point of dispensing and in depth for problematic patients. We were allowed to perform many more diagnostic tests: strep throat, diabetes, HbA1c, peak flow meters, and so on and so on. And the third thing we were allowed to do was to give vaccinations. The conditions for this are listed below. Number one, only a pharmacist registered for vaccinating after a 62 hours academic study and passing an examination. This was at the pharmacist's expense, both time and payment of locum pharmacists, or the loss of money if he had had to close his pharmacy down to study. This affected private community pharmacies, as only the managed care organizations or the sick funds pharmacies were paid for studying and obtaining this certification. The pharmacists had to have consulting rooms with a phone, a bed, a sink, and adrenaline injections on hand, and so on and so forth, all in case of anaphylactic shock or any other emergency. Next slide, please. Here you have a here we have a certification vaccination curriculum, which, excuse me, as you can see, included immunology, standard instructions of vaccinations, the necessity of keeping records, the demands given to for pharmacists wanting to give vaccinations, what type of vaccinations were available and could be given. A special attention was given to the influenza vaccine. We had to learn about side effects and effects between the effects of knowing the differences between vasovagal syncope and anaphylactic response. We had to learn about first aid in the case of anaphylactic shock. We had to hear lectures and practice what was being taught in workshops, and we had to learn about how to deal with elderly patients and different ethnic groups, because we have a very large variety of ethnic groups living in our country. We had to study about aseptic rules and methods of giving vaccinations. We had a lot of necessity of doing practical exercises in giving such vaccinations and learning of the side effects that could occur after vaccination. And again, we had to go over again the differences between vasovagal syncope and anaphylactic shock. There were examinations held afterwards, and those who satisfied the requirements of these examinations were then given a certificate to vaccinate. Next slide, please. Well, what the regulations failed to consider were as follows. And I see by our former speaker that many of these things we have in common. First of all, there was no minimum fee agreed to by any of the managed care organizations, of which we have 4, and the whole country is divided into patients attending one of these managed care organizations. And today we see that a home visit for a managed care organization to come to your home and give you a vaccination was about $10. Well, if you've got to close your pharmacy down and go and visit somebody and give them an injection and then go back, and all you can bring into the pharmacy is an income of $10, you start to realize where one of the major problems laid. Money was not refunded for any loss of time whilst the pharmacy was closed, whilst having the week study, and therefore the pharmacist had to pay for a locum and for any other expenses that were incurred. there was a big problem between the Ministry of Health and the managed care organizations, who succumbed to the demands of the physicians and the nurses not to permit this, either for fear of treading on their toes, for a loss of income that these professions might have incurred, or simply a threat to their kudos. A public explanation campaign to convince both public and Parliament of the need for easily accessible and speedy vaccinations at the time of need was not considered necessary. And this was a great shame. Obviously, the workload of the managed care organizations was going to be dramatically reduced. The fifth problem was that there was no assurance that all vaccines, as with other medications, would be administered and that were to be administered would be relatively easily available at the pharmacies. And this goes in line with what we all see throughout the world of medicine shortages. And finally, there was not even a thought of who was going to pay for the cost of disposal of medical waste after these vaccinations were given. Our society has been doing a lot of work, as you can see by the asterisks on the presentation. Next slide, please. So what should we really do? Well, first and foremost, have your association provide the necessary approved courses organized in-house at the time and place that is convenient for their members. The second thing, lobby parliamentary candidates and parliamentarians to understand the need for speedy vaccinations before the flu season and in the advent of as a pandemic, which has come upon us now, and everybody has been found, as we say in English literally, with their trousers down. The third thing, hold a public campaign, and this I see is the same thing that they found in Brazil. You need to hold a public campaign explaining to the public the advantages of vaccinating at local pharmacies, saving both time and money by not having to go to a managed care organization, a surgery, or any other hospital. The next point is the association should make available all the necessary equipment to quickly transform consulting rooms, which are obligatory in our country, as required by this new legislation. The next point was to ensure the equality of vaccine supply to all outlets. Why should we convince governments? Well, the added value of pharmacists helping in mass vaccination, particularly today that we have an aging population, is imperative and vital, particularly for the 65-year-olds. The World Health Organization recommendations for vaccinations are tetanus, diphtheria, pertussis, every 10 years, pneumonia vaccines, for all of those of age 64, unless of course they're immunocompromised, influenza and herpes zoster, and this is only to mention a few. So the question to ask our governments and our policymakers is, this is an enormous workload which is far too much for physicians and clinics and managed care organizations alone. So the obvious thing is to put it down into the pharmacies that are much more readily available than any other medical place where a person might want to attend to get medical attention. The next slide, please. So to back this, you can look up the references below for additional reading, because we have found tremendous help when we approach FIP and of the work that's being done by our colleagues and our peers all around the world. And there is nothing like convincing governments that, hey, look, this is being done in this country and that country. why shouldn't the same thing be done over here? Because the wheel has already been invented. It's not for us to invent it. So I would advise you to really go into this website and get all the information you need. And of course, I'm available if I can give any advice from what we have learnt. And we are continuing our fight. Some doors are opening, and what is happening now is because of the advent of the COVID-19 pandemic, ears are starting to be much more open than they had been in the past. Thank you very much indeed for your attention.
Thank you very much for this, Howard, to get a second perspective here on certainly the benefits, but also some of the difficulties of changing practice. So I now like to move to our third speaker, that's Shane Jackson, and then at the end we'll do some questions to the panelists. So Shane has broad clinical policy and research experience across several areas of pharmacy and healthcare in general. His interests lie in medication safety, quality use of medicines, and optimization of medication use in practice. He's a former national president of the Pharmaceutical Society of Australia and led a number of activities associated with the PSA directed at improving the safe and quality use of medicines. He's currently a policy advisor to the PSA. Shane is also practicing community pharmacist and owner of 3 community pharmacies in Tasmania and has significant clinical experience in aged care settings. He's director of consultant pharmacy services and provider of medication review services in aged care settings. And he has significant academic and research experience, having completed a PhD in pharmacy practice and a fellowship with the National Institute of Clinical Studies on translational clinical research. Okay, over to you, Shane.
Thank you very much, Ellen, and really pleased to be here and really pleased to be following Walter and Howard to talk about how we can overcome some of the impediments to implementing wider use of pharmacist vaccination. And I think what I'll talk about today will really build on what Walter and Howard talked about, especially the advocacy efforts around what Walter was referring to, and then the practical elements from Howard. So I'll take a more of a global overview of some of the things that practitioners and those in organisations in their own countries can take forward. The first thing I'd really like to highlight, and I think Howard did this also, is to try and utilise FIP and try and utilise your organisations to be able to promulgate messages around vaccination. So this is the publication that I've just put here that everybody can see on the slide is an overview of current pharmacy impact on immunisation. Now this was published by FIP some time ago, but what it will show is the variation of what pharmacists are able to do from a vaccination perspective across different countries. And I think Howard raised this issue when it comes to advocacy efforts. No politicians or policymakers like to be seen that they're behind other countries. And utilising reports like this and utilising developments that occur in other countries as rationale and evidence for the same development that needs to occur in your own countries is an important way to be able to progress vaccination efforts in your own countries. So I'd encourage everybody to look at this report, which is the FIP report, an overview of current pharmacy impact on immunisation. And this might be a call out to my FIP colleagues on the line, but given that this report was 2016, may well be time to look at how things have developed and have an opportunity to show how different countries are and utilise those efforts. And so, as I said before, what people can do is to utilise reports like this in your own countries, in your own FIP member countries, to support policy and legislative change or law change in your own countries. Next slide, please. And staying on the FIP resources theme, a couple of years later, 3 years later, after publishing that background report that showed the variation and the development, so to speak, across FIP member countries, this FIP Global Vaccination Advocacy Toolkit. So really what this does is actually puts on the table in very clear language and in an implementation plan about how you can go to the policymakers, to the politicians, to the people that make decisions about who is able to vaccinate in countries. This advocacy toolkit is an extraordinary resource produced by FIP to assist in planning vaccinations by pharmacists when it comes to adoption, and importantly, given that we have quite a significant amount of FIP member countries with vaccination as part of the pharmacist toolkit, importantly around expansion. So I commend this report for everybody to look at, because it provides four main areas in my view. The evidence base. So this allows us to refute any of the issues that might be put forward by policymakers, by other health professionals. Often now medical doctor colleagues might be against pharmacist vaccination. So this allows us to talk about the evidence base. It also allows us to articulate how we might approach stakeholders and have support. Often patients and consumers and the public themselves are our best advocates around expanded vaccination. And again, as Howard indicated before, the training is absolutely vital. This should be done by FIP member organisations in their countries, enabling their members to be at the forefront when it comes to vaccination efforts. And then when you overcome those hurdles from the decision makers around vaccination efforts, there's some fantastic implementation resources in this toolkit about how you can then roll that out, whether it be within community pharmacy, whether it be in aged care, or you may well have pharmacists vaccinating within general practice or in other areas. But as I said before, I commend these two fantastic FIP reports from 2016 and 2019 to those on this webinar. I think one of the main things, and I'd like people to try and take this away from my presentation tonight, it's to show, it's to highlight what the need is when it comes to vaccination. Most of the time, the need is about trying to reach targets. So most of the FIP member countries, the governments will have targets for vaccinations, whether it be influenza, whether it be tetanus, whether it be diphtheria or pertussis or any other vaccine. There will be targets. In a large number of circumstances, those targets are not being met. If they are being met, often those targets should be higher. And I think what pharmacy can do is provide the solution to government about increasing reach and able to meet vaccine targets. When you're able to meet those vaccine targets, then you're able to reduce the communicable diseases and reduce the consequences of those preventable illnesses that vaccines are trying to prevent. what we have in Australia is a number of states or provinces or counties, as they may well be in other FIP member countries. Each of those states, the governments decide what occurs from a vaccination point of view. And so what we're able to do in our own country here in Australia is that when there is a development in one state, we're able to highlight that variation to the other states that haven't yet moved and say, well, we need to be like this other state, and creating that variation and highlighting that variation is important to be able to get development occurring from an advocacy perspective. Next slide, please. And there's a number of reasons why I've repeated data on this slide, because data is king. We should all be encouraging our governments to collect data, and data being at the most granular level that we can in the states and across your countries. Because collecting data at a very granular level allows us to say that there's variation in vaccine uptake across the country. And so an example here is vaccine rates in children across the Australian population. And you see there that there's quite high uptake in certain areas, but there's quite low uptake in other areas. And so this data allows us to say that there's a problem. And that problem is something that pharmacists can be part of the solution in. So it doesn't necessarily mean that pharmacy organisations in a FIP member country need to collect the data themselves, but they must be advocating for their governments to collect that data on the most granular level possible. If that data is not being collected, then I think it's incumbent on FIP member organisations to work with academic partners within each of those countries to be able to identify where there is variabilities and look at what the barriers to access are. And in some cases it might be cost, in other cases it might be access because of limited convenience in accessing the vaccination. And we know that pharmacy is a very convenient site when it comes to access for vaccinations. Next slide, please. And I think just before I sum up with the FIP development goals, the main message that we should be putting across to policymakers and to those in the government around why pharmacists must be included in vaccine efforts, it's because of access. It's because of access, and because of that access, we can achieve a number of goals. The main goals that we can achieve is that we can reach targets. We can potentially decrease costs associated with vaccine distribution, and we can often reach those most vulnerable people in the community because of our close contact with those individuals. Other areas that improve access is that we have a workforce that, when trained, is ready to do vaccination. And if we just look at the COVID-19 pandemic that we have now, when it comes to distribution, pharmacy must be included because governments aren't going to be able to vaccinate the numbers of individuals that we would like to vaccinate without including pharmacy in that mix. So that distribution chain is vitally important. From a cold chain perspective, pharmacists have been managing cold chain for a long number of years and do it better than most other health professionals. So we're trusted, we can manage the cold chain, we have touch with people that others may not have touch with, and I think it's important that we push that forward. Pharmacy, in my view, can own the immunisation and vaccination space in most countries. Now, whilst nurses and doctors might be the administrators or the deliverers of vaccines in a large number of countries, we can be the advocates when it comes to immunisation, because in most countries, in probably all FIP member countries, pharmacists have them, especially community pharmacists, have the most frequent contact with patients compared to GPs and compared to nurses. So we can be those people on the front line. We can be the immunisation advocates across the world. We can be much better than doctors. We can be much better than nurses because of our frequent contact. And the policymakers and those in government need to understand that. We see many more people than others. So from an FIP development goal point of view, and again, I think FIP needs to be commended for the work that they're doing and have done in this area. Around policy development, this is really around having clear pharmacy-led strategies to develop and implement needs and evidence-based practice-related policies on service implementation, integration and remuneration that links with national health priority areas and policies. Expanded pharmacy vaccine services tick all of those boxes. We have an evidence base, we have implementation programs for service implementation, and they absolutely support national health policies and priorities. Governments need pharmacists to do more in this area. Next slide, please. So from a practice element point of view, and I think the FIP development goal around policy development really provides the framework for us to be able to move forward in expanding vaccine efforts. We can utilise the resources that have been created by FIP that are there waiting for utilisation. Those policy tools and regulations, and looking at the developments that have occurred across FIP member countries will give us the ability to be able to promulgate more vaccine developments across the world. And I think those policy developments and with the COVID-19 pandemic allows us to have I think a wave of policy changes that support more integration and expanded services from a pharmacy perspective. So all of our organisations need to be knocking on the doors of those policymakers and those in government to say, you need pharmacy, you can't do it without us. And we've got the systems to be able to ensure that it's done safely and effectively. Thank you very much.
Okay, thank you very much, Shane. And again, to all of our three speakers, really interesting perspectives here from the different countries around clearly barriers of the implementation of vaccination by pharmacists, noted the opportunities that COVID offers and actually how it's brought the perceptions of everybody, the importance probably up the agenda, recognising the perceptions of patients and doctors, maybe some of the doubts about pharmacists being able to deliver, the importance of actually getting everybody round the table and actually convinced about the value contribution that community pharmacy can make here, and the kind of legislative changes that are required and issues around remuneration, of course, as well. Is we've had another question, or another couple of questions actually from Ronald Goose, which maybe Shane has addressed already to an extent in his presentation. That's about, do any of the countries presented have a central database to track the individual patient vaccination record? And as a follow-up, if they do, do the community pharmacies have access to the database to view and input vaccination information?
Yes, so thank you very much for that question. It's a very good question. So in Australia, the answer is yes. So we have what's called the Australian Immunisation Register, AIR, and every health professional who administers a vaccine has access to that register. Every health professional that administers a vaccine is meant to, and in most cases does, because it's often part of legislative responsibility, provides that data to the Australian Immunisation Register. And so we not only are able to write to that register, so to speak, to input data into that register, we're able to view that register to be able to see what vaccines an individual has had, obviously with their consent. But that's a vital part of the tracking of who is administering vaccines, who has received a vaccine, and therefore whether we're reaching the targets that are needed within our country. So yes, that's vital, and our government's actually just implemented, it's just started a review to see if there's barriers to access from a health professional's perspective around that register.
So I don't know if one or two of the other speakers have got anything to add from their own country perspective, maybe.
I did write an answer in the Q&A box. Howard Rice speaking. Those pharmacies that are registered to vaccinate do have access to the vaccination records of the patients. Primarily, most of these pharmacies are pharmacies in the managed care organizations that automatically have all the patient records anyway.
Okay, thank you. Thank you very much for this. Unless I've missed something, I don't think we've got other questions in the Q&A or chat function. Please correct me if I'm wrong. So can I just pose a question to each of the panel members? From your experience, what's kind of the key message, the most important, that may be difficult, but the most important message to other countries who want to tackle this, who may not be quite so far down the line, what the important connections are that they need to make?
If I could answer the question first, Ellen, I think make public awareness. The public are the ones that will make the governments change their minds. And if there is demand, a sufficient demand, the public will do everything. We're seeing this in the United States at the moment. So this is general for everything, not just in ordinary everyday politics, but certainly in pharmacy.
Yeah, Ellen, I think it's really, so for those countries that very early on or have very little adoption of vaccination, I think it's about starting with influenza. So that's probably the first thing, starting with influenza and starting with access. And I think when you're meeting with the politicians and the decision makers, you talk about access and convenience, because there will be politicians and there will be policy makers who haven't had a vaccine, an influenza vaccine, that should have. And the reason that they haven't is because they haven't made an appointment, it hasn't been convenient, they just haven't got to the person who's able to give them the vaccine. But when you ask them how many pharmacies have they walked past and whether they could have had that vaccine at that pharmacy, they'll go, yes, I could have. So that's the first thing. And I think it's then, and this is not, this next statement is about no way diminishes vaccine administration. But vaccine administration, especially when it comes to influenza, is largely a technical task. Right? It's very, it's a technical activity. It's not difficult. And when you say to that person, have you ever had an influenza injection, and how long did it take, and what did they do, and do you know pharmacists could do that, and wouldn't it be more convenient if you could go to your pharmacy for that? They will be the ones, because what it does is it combines Howard's comments about the public with the decision makers, because the decision makers in that case are the public. And so they will help drive through that because they can see it for themselves. They've actually personally experienced the difficulties in getting a vaccination. So, that's my advice is, provide that real world scenario around, wouldn't it be more convenient if you could do this?
As we've got a little bit of time, I'll pose one final question, unless I get some other questions in the Q&A box as well. What specifically do the panelists think is the importance of getting doctors on board, who are probably the traditional prescribers, and that is there an opportunity around vaccinations to work towards a better integration across primary care provision with doctors and community pharmacies?
Ellen, if I can just add something to what you just said, answer your question. I think that this is starting to happen now. Pharmacy is becoming more clinical, and physicians are starting to understand that by having a pharmacist by their side checking on what they're doing is a great benefit. Defensive medicine has become so important and such a threat to physicians and pharmacists. But we've made fewer mistakes than the doctors have done. And I can always remember that wonderful article, cartoon of a pharmacist saying to his patient, you better be friendly with your pharmacist, he stops your doctor from killing you. So this is really what's happening today in the real world. So it's just a matter of time, and by us doing more vaccinations and doing more clinical pharmacy, we will find ourselves up along with the physicians instead of just paddling behind them. Thank you.
I think, Ellen, pragmatically, it really probably depends what the remuneration structure is for doctors. So if doctors are largely salaried, then I think they're generally happy for other people to help with their workload. In Australia, it's largely a general practice, so family medicine is largely a private enterprise. So there's less desire, I suppose, to have others taking some of what they might refer, and my medical colleagues have said this, some of the easier work away from them. So that is a challenge, and that's where government needs to incentivise family doctors to do some of that more complex task, which we know that they need to be freed up to do, and allow pharmacists to support some of these other activities because of our accessibility, etc. So it depends, but either way, the model needs to be embraced, because family doctors need to be doing other things because they're better utilised doing some of these other complex tasks, and they can have other health professionals, including pharmacists, do these tasks which are well within their scope of practice.
That's really helpful. I think we're having problems with the translation function, so we're wondering if Walter could maybe provide his answer in a written format, possibly not within the time that we've got left, but possibly afterwards, so we can translate it into English. I can't see any other questions coming through. I think. So I've hogged some of the questions, but I think we've raised here all the various barriers, but also the great opportunities that are here, and how we can inform policy at a global, at a national, at a local level, because of course all the systems are different in the different countries. So unless there are any other questions, I suggest that we bring today's session to a close. So I'd like to just tell you that we're going to pull this discussion together and feed this into the next stage of the process. And then also on the slide that you've been looking at here for a while is a reminder that there is an episode 4 on pharmacist vaccination and communicable disease management, the development goal 16 here, which is on the 10th of November at 1400 Central European time, and which brings us to the last slide, where I'd like to thank everybody who's made time to actually attend today's session, who've participated in the questions or actively listened, and a particularly a big thank you, of course, to the 3 speakers, and obviously to FIP for making all of this possible. So I can close the session unless there is something else anybody would like to say or contribute further.